Sorry, what was the question? Remind me of the question again.
Yeah, about this exam
Oh yeah, so the competency exam. So
confidence.
the idea is that we have the critical thinking skills, meaning that we data that we're learning in this class and other classes, and we're applying it to what pictures we're taking in the lab. So I'm a believer that just taking a picture that's parasternal long axis, for example, just because I take that picture and make it look pretty doesn't mean it has the diagnostic characteristics that I need to show. So the idea of that is that we need to recognize when we need to recognize when we're taking that picture for this pathology or that pathology, whether it's proving that this is true or not true. So the idea of that competency is that you'll be given a pathology typically, and your job is to go through and take the pictures that apply to proving or disproving that. Does that make sense?
Yeah. So, for example, if the we have like aortic valve disease, right? So we need to know, uh, like additional to this exam, do we need to know like all pathophysiology and like what view we're taking, right?
Yes.
Mm-hmm.
So before we even start talking about aortic valve, so let's talk about that. So if we thought there was something wrong with the aortic valve, what do you think? Which pictures would you show me that relate to the aortic valve from what you know so far in lab? Just give me some examples.
Zoom aortic complex, high ascending, check that, and then sacs at the base.
Okay. So we're showing things that relate to the valve directly, right? Yeah. So why do we take it in Zoom in peristernal short axis, for example? What do you think you're looking for on the aortic valve? Now,
Isn't it defects?
okay.
Good.
Give me some examples of defects.
Just
Like,
thickening, we're looking for like closure,
Good. So
bicuspid, tricuspid.
first of all, we're looking for things directly related to the valve, right? So we're looking for breaks in the valve. We're looking for lack of closure or lack of coaptation. We're looking for thickening of the valves, for calcifications on the valves, for things hanging off the valves like masses, tumors, vegetations, those sorts of things. So we're looking for things that are affecting directly the ability of the valve to work normally. We're also looking at the valve to prove that it's thin and pliable and that it's opening the way that it should structurally. We're also looking for things that are congenital. So when the valve is formed correctly versus not formed correctly. So those are all things that we're looking at with the valve. Then we stick color Doppler on that. What do you think we're looking for in color Doppler?
regurgitations.
Okay, so we're looking for flow abnormalities or if the flow is normal. Okay, so that's just as important as looking for abnormalities. So we're looking to see that it closes, that it doesn't leak for one, that in color Doppler, you can actually appreciate and see stenosis as well. So if I see that in 2D, it's being restricted on its opening, I expect when I put color Doppler on to see kind of a confluence of flow going out that's aliasing. It's, where normally it's wide open, it can just flow freely through it. I'm now looking for a restriction, and I might see that in color Doppler. We might also look for dilation of chambers that's a little bit less directly related to that valve itself, but it's still going to affect everything else. And then when I stick my pulse wave on and my spectral Doppler on, I'm now quantifying via the flow Dopplers how much flow, how fast the flow, those kinds of things are occurring, and comparing those to the normal tables and charts, and the severities and stuff, so we can grade exactly how severe that is. So that then they can make the next clinical decision to either go to another test or to do surgery or what needs to be done. So that's kind of the idea of that competency, is to be able to take a pathology, and it could be broad, because in the clinical world, it's often very broad. So they come in with something like shortness of breath, they've got some syncope, um, particularly with exercise, for example. So we have a differential of things that we need to exclude and include when we're taking our pictures and trying to document. So We're trying to put off the things that aren't going on and focus on the things that are. And we may never come down totally to one specific disease pathologic reason why this is happening. It may be two or three reasons, but we want to narrow it down as much as we can with our echocardiogram. So that's kind of the idea of the critical thinking, is knowing what pictures am I taking that apply to this pathology or that pathology. Does that answer your question then, Arena?
Yes, I think so. So if, for example, you're gonna give us pathology like aortic stenosis, and you're gonna ask us which uh, view we need to apply, like these things. Okay,
Yep,
thank you. Yeah.
exactly. And it may not even be as specific as aortic stenosis. It may just be aortic valve disease.
Mhm.
So tell me stuff that relates to the aortic valve. So in that case, you're going to include both regurgitation and stenosis. If I ask you just for stenosis, then we're going to go over more specific things. But yeah, it could be any number of things. I usually randomize it so that this is when I do it. This year, I'm not the one doing it. It's going to be Tyler and Tammy that will be doing it. I usually have two people together doing it just so we witness it. Um, so it will be based on something like that. They have the leeway as instructors for that class to modify that from how I used to do it, but I found it actually quite very effective on predicting how somebody will be in clinical situations. Okay, because in the reality, in a clinical situation, if we don't see it, the doctor doesn't see it, and it's very, very important that we do have that critical thinking step. We can take a picture of a tricuspid valve, for example, in long axis and in short axis and in four chamber view, but does that mean that you saw the pathology that was there? I can show you lots of pictures of a tricuspid valve, and I can be off the slice of where that regurgitation is occurring. I could be not showing the correct leaflets that actually have the disease state, and I can miss it completely if I didn't sweep through my image gradually looking for that specific pathology. So there's techs all the time that miss disease processes just because they throw up a picture of the tricuspid valve, not deliberately going after what's happening on the valve. So a good tech is going to be surveying and looking for those things. If we don't see it, we typically will just go into a nice picture of the valve and show that. But remember, your shadowing and everything like that can also limit or minimize the evidence of that pathology that's there, because that little bit of shadow can hide, a leak. It can hide other things. So the tech has to be deliberate to make sure that they are in fact showing the real structure and the complete structure. And then keeping in mind that although we're looking at a three-dimensional valve, I'm only showing you one slice of that valve, one very thin slice. The presumption is when I take a picture of the valve is the doctor's trusting you that you had looked all the way through that valve and not just gone to that one picture. I could relate that to doing like a venous exam. You may start at the femoral vein, and you may do a proximate and distal. And there's many techs that I've personally seen, and I think it's disgusting that they do it. They'll go to prox, jump to mid, jump to distal. And as I'm sure Kelsey can attest to doing these exams, and Sarah as well, that as you go through those, you can miss segments of clot and thrombosis and stuff like that that are happening because you jump from one spot to another and you skip a whole big segment. Okay, so it's really important that you saw the entire thing. And when I take my protocol pictures, the assumption is that I saw the entire thing and I'm showing what's relevant. So that's kind of the concept of it. It is a timed exam. There's no accommodations for that. It has to be done in the time limit that's given, just like we did for our for our stress echo images that we had in our 2 minutes. Those are things that are relevant to clinical, and that's how those are. So yes, it's stressful. I don't think it's a bad thing to have a little bit of stress and anxiety. I don't want you to be totally panicked. We know this now, so as you're studying, when we study these things in lecture, I want you to always be thinking, okay, how does this relate to the pictures I take? Okay, what pictures do I need to show to prove that? For example, I had a aortic stenosis study that as a new graduate, every tech makes big mistakes sometimes. I just hope it's not a super big mistake. But I got through this study. It was an aortic valve stenosis study, and I was super proud of myself for getting this super high velocity, and I thought it was just the greatest thing ever. And then I got out, the patient's gone, and I'm writing up the study, and guess what? I forgot to take the LVOT, pulse width. Okay. Can I diagnose the aortic stenosis just on velocity alone? I cannot. I have to have a comparison to the LVOT. So what do you have to do? You got to bring the patient back and you got to rescan that information. Okay, it's a pain. Those are the mistakes that we learn from. Obviously, it affects me to this day. It drives me crazy that I missed that. Something so simple, something that's part of the regular protocol, but you get excited in the moment because you're seeing this crazy pathology you've never seen before to that degree, and you get all excited and you miss it. Okay, another case when I was a student, I was scanning, and the person I was working with were up at the epigastric area, looking at the liver and the pancreas and stuff like that. And right away on that study, we could see this huge cystic area right at the transducer. And we're like, what is that? And so your brain's going off in all these different directions, trying to think, oh man, I just found this thing. It's going crazy. And the thing that the tech pointed out to me is like, you got to stay focused on what you're doing. We will get to that when we get to it, and we'll document it when we need to document it. And so that was a good lesson for me, because you can easily miss it. It turned out that that was the patient's urinary bladder seeing all the way up at his xiphoid process. It was immense. But, you know, had I gotten distracted and just started following that rabbit hole, I would have missed the important stuff for the rest of the study. Okay, and we can't do that because there's other things that could be going on as well. So don't get lost in what's going on at that moment. That's why we have protocol. So I hope that answers your question on the competency exam. So like I said, it will be a little bit up to them on if they decide to change the format or use the same format. I've done both written and live scanning, so it could be whatever they see fit. The testing modality is not important. And the important thing is connecting what you're looking at and justifying your pictures relative to that pathology. I have had students that, you know, in the past I've given them diastolic function, for example, and what do? They start measuring ejection fraction, which is a systolic function thing. So don't be complacent in it. Like, I'll just wing it. Don't wing it. You need to study for it. You need to prepare for it. Those that prepare do well. Those that don't prepare, they're the ones that struggle. They're just throwing stuff out there and hoping it sticks. Okay, that's not what we do in echo. If people want to do that, they can go to a different echo program. My program, I want techs to come out knowing what they're doing. We call the difference between those picture takers versus people that are looking for pathology, because just taking pictures doesn't mean that you're showing or not showing the right processes that are going on. On that note, let's talk about aortic valve. So this first part is going to be particularly for aortic stenosis. Tomorrow we will discuss aortic regurgitation. So we'll start with the valve. Just start as we started discussing here is the nature of the valve itself. So know what the normal looks like. So we know that the aorta has 3 leaflets. They're roughly equal size in their presentation. You do need to know each individual leaflet from each perspective. So when we're looking at it from peristernal short axis on the ASE's peristernal short axis presentation, we've got our, as you can see the picture there, the right coronary cusp is on top. To the right lower to that is the left coronary cusp, and the one to the left lower from the right is the non-coronary cusp. Okay, guess what coronary artery sits behind the NCC? Yes, that again. Guess what
Left.
coronary artery sits behind the NCC, the non-coronary?
Neither one, right?
Neither
Nothing.
one.
Yeah, it was, yeah,
The other ones are too easy. So what's behind the LCC?
the left,
The left, and the RCC?
the right.
Right. Good. Just testing. So we know that those coronary arteries come off. We know there's only supposed to be 2. Okay. Are there situations where there might be a difference in that presentation?
Yes, my little cousin has that.
Yes. And it can be a sudden cardiac death scenario. It can be a situation where if it gets blocked off and they didn't know about it, that could cause the patient to go into a heart attack and have some major problems.
I think, can I
Um,
make a note? I
yeah,
think she
absolutely.
actually has to go into open heart surgery because of that reason.
Yes. So if we know about these things, and this is a good take-home message, if we know about these things, there's a lot of things we can fix. Okay, I just mentioned sudden cardiac death in that term. What do you think that means? That means all of a sudden they have cardiac death. The patient dies literally. And so there's other scenarios that sudden cardiac death can come into play. But do you think it's important that if we were looking at that structure that we notice that, or just let the patient go and go about their day and maybe we'll catch it later? It might be too late. Okay, so it's very important that we do pay attention to these things, even the most subtle things. That's why you have to scan through the entire aortic valve. You're not only looking for the valve leaflets and to see that they're thin and pliable, we need to see that there's 3, not 4, not 2, not 1. We need to see that they attach where they're supposed to, that even if it looks like there's 3, is it opening like 3, or that or is one of those commissures closed? We're also looking at the wall to see that there's not a defect in the connection between the aorta and another chamber. Okay, so all those things are important to pay attention to. That's why when you zoom up on the valve, we want to make sure that the zoom is appropriate so that we don't exclude any of that information. We need to be appropriate enough to see the anatomy we need to see, have our reference, but be big enough to get the detail resolution that we need to see. And then, 2D is not enough for that. If we don't see it in 2D, you might still see it in color Doppler. So seeing the color Doppler and it covering the same area is also important. So know your normal anatomy. So each of these leaflets is surrounded by a sinus. So the aorta in short axis at the sinuses of Valsalva is not a round structure. It's kind of a cloverleaf shape, okay, with an inverted Mercedes-Benz sign, or like a peace sign, okay? And that's what the normal should look like. People don't usually pay too much attention to this, but I just want to point it out since we're here. And you'll see as I draw these, notice that the tricuspid valve attaches where the commissure of the non and the right coronary crossbar, and the pulmonary valve attaches to the area right across from the commissures between the right and left coronary. I don't really hear people talk about that much, and then the interatrial septum actually comes off about the midpoint of the non-coronary cusp. So those are just some correlations that you'll get to know as you're scanning, hopefully, or maybe you don't even notice it. Maybe you just subconsciously notice it, and you'll know when it looks not right. Okay. So one of the best things you can do in the world of ultrasound is trust your gut. When you're scanning and things just don't quite look right, maybe there's something going on. Maybe you should explore that more. Which means that you need to explore different windows, different perspectives to see and confirm that things are in fact normal or not. Okay, so we've got those cusps all surrounded by a sinus. They're separated by 3 commissures and are supported by the fibrous annulus. So remember, the fibrous annulus of the heart, the electrical base of the heart is formed by that fibrous material that does not allow conduction to go across it except at the AV valve and the bundle of His. So that's supported by that structure. The aortic valve in long axis, I should specify that, is crescent shaped. So crescent being kind of like a half moon shape. The valve should close tightly. It should not leave gaps. If you see gaps in 2D, what do you think you'll expect to see in color?
Blue.
Regurg.
Blue or red, depends on our perspective, but we're going to see regurgitation. Yes.
I thought we were still talking about long.
Yep. If it's in long axis, correct, it's blue. So it should close tightly. The node of Arantius is where all of the slightly thickened at the tips or at the midpoint, so where they all meet in the middle, is called the node of Arantius or nodule of Arantius. Okay, right there. I always have to tell this story because I'm proud of my students that that thrive in the clinical setting. As a student, someone was here locally here in town, and the surgeon was asking, I believe it was a surgeon and a doctor, regardless, was asking a resident what that structure was. They're pointing to it, and the medical resident couldn't quite figure it out. And my students like, can I ask? Really shyly. And they're like, yeah, go ahead. And they're like, yeah, it's a nodule. Is it a nodule of Urantius? And he's like, yeah. And he's like, you just got shown up by an echo student. It was awesome. So the little things matter. Again, it's kind of a Y-shaped in parasternal short axis. This presentation that you see, it's could also be called, you'll often hear it referred to as an inverted Mercedes-Benz symbol.
Could you trace that out on the image? Because I'm unfamiliar with that a little bit.
So you're looking at the commissures, these here. Okay. So Y or inverted Mercedes-Benz. Again, I mentioned earlier, maybe you see the 3 leaflets. That's great. Doesn't mean it's opening like 3 leaflets, because maybe these two are fused together, and it opens like a football shape, which would be a functional bicuspid aortic valve. We want it to open when these leaflets open. It should form a triangular shape. And Nancy, you got a comment?
Yeah, can you draw the crescent shape or trace it on another image?
It's going to be on a long axis perspective, that crescent shape. It's just that it kind of cups like that. So if we get to a long axis picture, I'll point that out. But it's
Thanks.
long axis for that crescent shape.
I think it's the next slide, Nancy.
Yeah, there will be one coming up. We'll get to that.
Okay, thank you.
So, so other things that could go wrong. So remember, now we're going to be talking a lot about normal stuff, but we're also going to be talking about pathological stuff. So between today's lecture and tomorrow's, now we're talking about pathological states. And so we want to make notes of this. You should again be building your portfolios as we go through each of these. And again, with your portfolios, just to emphasize, I don't want just what's in Feigenbaum. If you see stuff out of a journal like the JACE journal, if you see them and you're talking to somebody in a clinical site and they make a comment that you haven't heard before, I want you to make notes of those things, and I want you to study them. If you heard a term that you've never heard before, you should go figure out what that was and add to your portfolio constantly up until we pass our registry. And then maybe you can write a book after. Just kidding. All right, so so the disease, we have 2 different things that we talk about: valvular disease or any of these pathological states. We have number 1 to be congenital, number 2 is acquired. So what is congenital?
Acquired at birth.
Okay, so congenital is something it's a developmental thing that just didn't develop the way that it was supposed to, right? And then we have acquired disease. What's acquired disease?
You get it throughout your life.
Okay, yes. So Kelsey's first comment was it's acquired at birth. I won't say acquired at birth. I'll say it developed that way or didn't develop that way. So when I talk about acquired disease, the presumption is that it developed normally, and then throughout our life, because of our, it could be our genetics that contribute to it, such as high cholesterols and things like that. But these are things that through our genetics and our lifestyle and our environment influence what happens to those structures. So in this case, we're talking about aortic valve, that development of plaque and stuff like that on them, the calcifications that come on them. Those are acquired because of genetics and lifestyle. Okay, just because it's genetic doesn't mean it's a congenital problem. Congenital is simply that it grew incorrectly. Okay, they can have totally normal genetics and they can still grow incorrectly. So I just want to distinguish those 2 things. So typically in the adult echo world, most of what we will be looking at in our world, what we're training for, is acquired heart disease. We're going to be dealing with lots of patients that are older, that a lot of what they have experienced is just a concoction of what their lifestyle has led to, whether that's contributed by genetics or just like lots of sugar and fatty stuff and smoker and diabetes and other situations like that contribute to that process.
Can I consider acquired as chronic?
Yeah, typically it will be a chronic process in that it takes a long time to occur. So I would agree with that, yes. Nancy, go ahead.
Aren't we now starting to see more adult congenital stuff
Yes.
because they used to just not live that long, but because now in the last, I don't know, up to 50, I don't know, but 20 to 30 years, we've fixed a lot of things that used to, and so now we're, in addition to seeing
Yes.
older patients with acquired, we're going to see more adult congenital.
That's absolutely true. And so the biggest need in the cardiac world right now, if you're really looking for a niche for yourself, a niche, however you say it, adult congenital is probably the one to go after because of that. So yes, those kids that back in the day, they would have died with many of these processes that were going on. But now, because we have surgeries and procedures that can fix those things, and we've learned so much more about the heart, now those patients are living to be longer. And we've got a slew of echo techs that are adult echo techs like us out there that are good at what we do, but they don't have a whole lot of background in congenital deformations. And so a lot of those patients are being pushed back to pediatric labs because the adult labs don't know what to do with it. So you actually have full specialties of cardiologists that are adult congenital cardiologists, and you're now getting full specialties of adult congenital echo techs to go along with that. So if you're really looking for a niche for yourself in this industry, that's probably a great one to attack. It is a much needed field. We'll say that. So yes, we are seeing that. So it is important that we don't ignore these congenital things. But in this program, we're going to touch on it very lightly. You will have the pediatric section in the fall, but again, you're touching on it very lightly. There's easily as much content for congenital stuff as we have in just regular acquired heart disease stuff that we'll be discussing. So there's another textbook size thing easily compared to Feigenbaum that you would need to know in addition. But go that route. I would encourage all of you to get experience in the adult congenital stuff as well, because it is going to keep your job. Okay, so so we've got acquired, we've got congenital stuff. Or part of our job is to determine how it forms. So I mentioned already on the aortic valve, we could be having a bicuspid aortic valve because it didn't form correctly, or I could have a bicuspid aortic valve because the leaflets fused together because of all the plaque and stuff like that that just kind of became that way, and now it's functionally a bicuspid aortic valve. But those are important distinctions. So the causes of these can be degenerative. So of aortic valve disease, generally speaking, it could be a degenerative cause, meaning that it just kind of breaks down over time like our cars. It could be a rheumatic process. So people that had rheumatic fever back in the day and or other countries currently, rheumatic fever is still pretty prominent and they don't have treatment for it like we have here in the US. You'll see often valvular stenosis because of rheumatic fever damage to valves. Or it could be an infective process that causes things like vegetation. So I mentioned before the friend of mine that was picking his teeth with a dental pick and then got an infection that went to his heart and damaged his aortic valve. He ended up needing an aortic valve replacement. So those types of processes can damage and affect the valve. Normally speaking, most of our patients are going to be a degenerative process over time. We may have subaortic obstruction, so not the valve itself. So maybe we're noticing our Dopplers are very high velocities, but the valve itself looks like it's normally functioning, and so we're not that concerned about the valve. But what we should be paying attention to, and this does get to more congenital stuff here, is that maybe there's a stenosis of tissue that's causing a restriction before the valve or even after the valve, okay, a supraaortic obstruction. And so congenitally, we'd be looking for things like that. So this would be things like HOCM that we're going to talk about later, where you've got that super thick bulbulous type of formation on the interventricular septum causing a restriction through that area, combined with the mitral valve coming up and restricting the flow going out. Is that your comment, Mike? Okay. So those types of things, we're not only looking for the valve itself, but again, we're looking through the entire area. Kelsey, go ahead.
Could it also be like a mass or a vegetation that could cause a subaortic stenosis?
Yes, it certainly could be. I think it's less likely on that valve in particular. Mitral valve, for example, when we get into masses and tumors, they might have so the picture I showed you yesterday of that big mass going through the valve, that can cause a stenosis of the mitral valve. It's less common, I'd say, in the aortic valve, but not impossible. Okay, the other thing that we get, so it might be like a big muscular bunch of tissue. It could also just be a band of tissue or a false tendon. You know, our tendons usually go from the muscle to like the mitral valve on that apparatus, but maybe some of those go and span just across muscle to muscle and don't attach to the valve itself. And some of those can sometimes obstruct the flow as well, particularly if they become more broad or thickened. They can also cause obstruction. So we're just looking for anything that causes that flow to elevate and stream through that area. Okay, so we are paying attention to our Dopplers, but we're also paying attention to what's happening in 2D. Okay, so aortic stenosis then is the idea of restricting. So we've already talked about stenosis from an arterial standpoint, same concept, it's just now on a valvular structure. So this is anything that causes the valve itself to restrict flow. We have degenerative or senile. So that degenerative process, again, is just a natural breakdown process over time. So again, it's like your car, you know, at 100,000 miles is going to have certain symptoms. At 200,000 miles, is going to have certain symptoms. At 300 miles now, 300,000 miles is probably dead for gas cars. Diesels might keep going. But the point is we have that degenerative process. Things wear out. And that's what that is. And senile refers to age. So the senile type of patients, we usually think of patients as dementia and things like that, but it's just intending to say that they're older patients. So this is like your 65 to 70 years old-ish and older. Congenital stuff like bicuspid aortic valve is typically a young person's conditions. So if you're just noting what processes are going on, think of your patient's age. So if they're very young, you're going to be leaning towards thinking that it's a congenital problem and not a degenerative problem, okay, and vice versa. Rheumatic fever is a post-inflammatory process. So again, rheumatic fever is a fever, again, throughout the world. It's usually remedied by and treated by antibiotics. And again, in this country, we have very good antibiotics. We have very good access to medicine. If you go to a third world country, rheumatic fever is fairly common. And as far as mitral valve disease goes, it's actually the most common cause of mitral stenosis. And will have certain characteristics, but it also affects the aortic valve as well. Yeah, Kelsey?
In comparison to those other bullet points, how common is rheumatic fever, you know, in comparison to congenital, degenerative, or the other ones?
Depends what country you're in. If you're in a third world country, it's probably a good mix of congenital and rheumatic fever type causes, as opposed to degenerative, simply because those people don't tend to live as long because they don't have as good of access to healthcare.
I mean, okay, so speaking just for the America, for us, what we'll see here.
What we're going to see mostly is degenerative. There's a fair amount of congenital. Rheumatic fever is going to be a lot less, but it was a thing in this country for quite a while.
Right, right.
We still have a lot of older patients that had rheumatic fever, and so when we see particularly mitral stenosis, you're going to be considering, and you're going to be asking the patient, you know, did you ever have rheumatic fever or have rheumatic heart disease when you're younger? And if they've got stenosis, that's certainly going to contribute to the diagnosis. So not a ton, but it is there. And I will also add to that we're living in a generation now where we have a lot of antibiotic resistance. And because of that, some of these disease processes are coming back into the US because it's getting more and more expensive medications if there are any available at all. So we're starting to see probably an influx of some of those disease processes again. Nancy, you have a comment?
What did you mean by 9%?
That's just showing that overall in the US, 9% is about how many cases of rheumatic fever related or post-inflammatory. I would give those as being US numbers, not worldwide.
What, Scott, what are we seeing in those photos specifically?
Oh yeah, good. Sorry. I like to throw pictures up there just randomly, so but that's a good point. So in an echo, we see an aortic valve like this. So this is what we call a planimetry measurement. So we're actually tracing around the residual hole that we can think we perceive. Okay, remember that we get a lot of dropout, a lot of shadow, particularly when things get calcified. These are calcifications. These are chunky bits of calcifications on the valve itself. The valve also may be thickened from what we normally see. So that's how we see it in the echo. This is how you would see it on a pathological sample. So these are actual calcifications on a valve. Here's the valve structure itself. You can kind of see the thickening at the tip of the leaflets. And if we were to see the leaflets in cross section, it would probably also be thickened looking at it that way. But I just like to show pathological samples versus what we see in echo.
Yeah, so that's all calcification. None of that is like vegetation or anything.
Correct. Yes, this is typically a calcification here.
And
Vegetations are going to kind of hang off into the valve and they're going to dangle out into the fluid and they're going to be flipping back and forth. These are kind of attached to the valve. They don't really, they're kind of rigid in what they are.
what view is the 2D image? Is that?
That should be your peristernal short axis. It might have a little bit off axis on the side, but they're just looking at the opening of the
Okay, so
valve.
it's not like a 2D imager.
That is 2D.
Okay,
Yeah, so this is 2D and they've just traced it with a planimetry measurement to get an area. Yeah, Nancy?
Why? I why is the calcification showing up black? I thought it would shine white.
Well, they are white. So these are the calcifications here. This black space here is just the fluid, because remember the cusps are kind of cup shaped. We're only seeing the tips of it here. We're not seeing the entire valve, so we're seeing that. On this picture, sorry, let's go to the tracing. The tracing, they're not tracing a calcification here. They are tracing the opening of the valve. So that's fluid. So this is where it's not coapting. Okay, so the valve is supposed to be, sorry, this is during valve opening. So this is the valve open as wide as it can be. Okay, normally the valve opens wide up. We would see a triangular shape in short axis. Because of the calcifications, this commissure is fused at this point. We still got a little bit of a tri-leaflet shape to it, but this is as open as that valve can possibly get. Okay, that is stenosis. That's very, very restrictive. So when we do a measurement with our continuity equation, what we're trying to prove is how big is that area when the valve is totally open, how big is that residual hole? So this is one way of tracing it. It is not the most accurate way because calcifications, as we know, cause shadows and dropouts, and we don't necessarily know exactly where that line is. So therefore, our Doppler information is actually better at determining actual valve size than a planimetry like this. And you may not always be able to get this exact splice at the thinnest portion of that. So there's a lot of tech error that may come into play if you're trying to measure something in this method. Although technically it's an acceptable method. So if you got nothing else to do and no other ways to prove it, and you can't do your Doppler for some reason, this gives you at least an idea of how big that valve area is. So when we report on the aortic valve numbers, I always on the report want to see you report it as a AVA or aortic valve area. Okay. Yes, I want the maximum velocity. Yes, I want the TVI going through the LVOT. I want the LVOT diameter, but the number I'm most interested in is the aortic valve area. Okay, and likewise for the doctor. They'll also want mean pressure gradients and stuff like that that come from the TVIs. Does that answer your question on the on those samples then? I think it's helpful to see kind of what a real valve looks like with this stuff. Note also that in the current world we live in with 3D printing, with a 3D echo, a 3D CT, or a 3D MRI, they can send those data sets back and get them 3D printed, and they can actually print out an exact replica of that patient's exact, plaque burden or congenital disease and stuff, and they can use those to help teach patients what's going on with their own heart. They can also tissue type it so that the tensile strength and elasticity and stuff of the 3D printing mimics the actual tissue type. And so then they can actually test out devices and stuff and see what's going to work before they have to crack the patient's chest open and do the surgery. So super cool world. If you like all that techie type of stuff, I do. I think the 3D printing is super cool. We haven't gotten to the point of 3D printing a heart and just replacing it that way, but that is being worked on. So stuff like that is being done. Okay, so patient checks in. From the get-go, we can tend to have an idea of what's going to be going on with that patient based on their patient history and the physical exam. So before we even start the echo, we can have a good idea what's going on. We can start a differential process of narrowing down what is and what isn't the problem. So let's start with the patient history. So these are pretty much coming from, used to be Terry Reynolds, now it's Richie Palma, this book here. So if you go through this book, this is pretty much going through, and I always like this book because it very succinctly, bullet by bullet, goes through various points of each of these things, along with other imaging modalities and stuff like that, what you would expect to find. Okay, but it doesn't necessarily explain anything, it just gives you the details. So use that in conjunction with Begenbaum. If you don't have it, I do highly recommend it.
Scott, what is the difference between the newest edition and the previous?
One is the author, because Terry Reynolds, the one that started this, retired, and he passed it off to a guy that's very good. I know him personally. His name is Richie Palma. He's from Boston. He's now the program director at that new Duke program. So he's down at Duke Medical Center now. He's an ASC as well. So author is one. And then in addition, sometimes they just add a little bit of information to these books. Sometimes they take stuff away. So there might be some slight modifications in it. Either one of the books is really good. Just to show you.
Is that the pocket handbook he's talking about right now?
Yes.
Yes. I just was curious about content differences, but
I went to go buy it at the bookstore and they do not have it. Could you ask them to get it again, please?
They typically won't send it to me until fall or till next winter. So I would actually recommend just going to the Arizona Foundation, is what it's called, or Arizona, yeah, just Arizona Foundation is the publisher of it. You can get it directly from their website. It's probably cheaper. So when I was a student, this was my book. This is the second edition. There was some variances in that. This book, as you can tell, is pretty well used. This was my favorite book when I got out to clinical and I became a tech and was working, because I could go in, I could find what pathology I was looking at, particularly if it was something rare, and I could go through and find out exactly what pictures I needed, what measurements I needed when I went into the room. So this really, I love this book for that. You can see it's pretty well used. My version of it had a how-to section in the back, and doing things like PISA and stuff. This was all kind of new at that time. I could go directly to this. I could go to the PISA measurement, and again, I could look up exactly what I needed to do and come in and out of the room. The next version that I got here, this is the 4th edition, so there's one in between that. This one was Terry Reynolds' last one. What I like about this one is that it actually has a whole peripheral vascular section in the back as well, which I thought was pretty cool. It was an addition from the previous versions. And then they kind of relabeled the chapters and stuff. So it's not called the how-to section anymore, it's something else. This new one just came out, and I don't think there isn't a measurements and stuff section, but I don't think it has the peripheral vascular anymore. I think it's just cardiac now. So this newest edition is just cardiac. It's probably got some new additions and some updates to it. And then there's actually a pediatric version that's just as thick as this, that goes through pediatric congenital stuff as well. So I quite like these books. Again, they're good. functional book for when you're in a lab scanning, because it gives you charts and tables and what you expect to see in patient histories and physical exams, and if they had an MRI or nuclear medicine and all these other things, and they'll have some little pictures in there as well. I think it's a very good reference book. It's not a book that's going to explain anything.
Hey, Scott, I have the 4th edition, that last book that Terry did. Is
Yeah.
that, you think that's okay?
I think it's a great one. Yeah, I'd be perfectly happy with it. I just like to keep the latest one because as I'm teaching, I like the latest versions. But can you get through the others? Absolutely. Echo doesn't change that much. There will be things like TAVRs and stuff, which is a aortic valve replacement. It's a stent valve. Those things were new since I was a student, so my version of that that I had early on wouldn't have the same stuff. So that kind of stuff progresses. So those would be expected to be found in the newer editions. But the last 4th edition is pretty current, I think, for a lot of stuff that's going on right now. All right. In other words, if you already have it, I wouldn't go buy another one. Not at this point. Get your, I think a good lab should also have a good access to good textbook resources as well. So if you get into a lab that doesn't have them, you might petition your manager to get some good textbooks like this to have as references. The other one that I would make sure to have in my lab is the newest version of the ASE's textbook. I think it's very good as well. There's a new one coming out. It's just not totally finished yet.
Hey Scott, quick throwback. I know you can't see the chat. Casey asked, did Scott say that Doppler was the most accurate for determining aortic size?
Stenosis, yes.
Okay.
Yes, that is correct. And thanks for pointing that up. Okay, so patient history. So the patient walks in the door, they've got, why does a patient come to you in the first place?
Pain.
I don't know, my doctor told me to. You do get some of that. Usually it's pain, something abnormal. I know Dr. Foos likes to talk about patients often, especially in the cardiac world, patients are in denial, so they don't want to admit that they have disease processes, especially us guys. We just tend to be that way. I'm no exception to that. I will be the last one to go. If I'm in the hospital, I'm dying, okay? And I probably am dying. And so I'm going to wait as long as I can. I probably shouldn't do that in the world of preventative medicine. If I want to extend my life, I should take care of myself better. But the reality is patients don't come in until it's really bad, especially when it's to do with the heart, because when you come in with the heart issues, what are you usually thinking?
Oh crap, I'm gonna have a heart attack. I'm gonna die.
I'm gonna die. Yeah, it's usually pretty bad by then. Another one that tends to get people to actually get off their butt and come in is when they're coughing up blood, right? Stuff like that that's just like, oh, this definitely ain't right. Okay. Never mind that pain that I've been ignoring for so long, or that long-term infection that I had going on that I could have had treated and pretty easily. So, you know, short story is we should do better at preventative medicine. I'm not a great advocate for that because I'm hypocritical when it comes to that, because I will wait to the last second. But most of our patients with aortic stenosis are going to come in with these types of patient histories. So they're going to have dyspnea on exertion. What is dyspnea?
Shortness of breath.
Hard to
Shortness
breathe.
of breath. Yep, shortness of breath. They could call it various things. A patient isn't going to come into you and be like, I have dyspnea on exertion. They're going to be like, oh, I get short of breath, particularly when I exercise or do this or do that. Okay. They might have congestive heart failure. They might have, and it's not that this is a totally inclusive list. This is just a possibility of things that they could have and likely do. And the worse it is, the more of these they probably have. They might have angina, so angina pectoris, just the chest pain. They might have effort syncope. So what is syncope?
Loss
Fainting.
of consciousness.
Fainting. Yep. Fainting and collapsing. So the effort is important because they could just have syncope just generally, or they could be doing it particularly when they're exercising. Okay. So from a cardiac standpoint, I'm always thinking, okay, the heart's job is to pump blood, get oxygen where it needs to be, transfer nutrients, etc. When it's not doing its job, or when I've got this going on, and the aorta is one of those things that if it's restricted, guess what? I'm not getting blood where it needs to be. My heart might be trying to work hard, it might be trying to do stuff, but it can't get through the valve. That's the problem. So it's no surprise that these patients have syncope or syncopal episodes, particularly when they exert themselves. Okay, so ultimately the brain's not getting oxygen. When the brain doesn't get oxygen, it does a temporary shutdown. It's the body's way of leveling the playing field, so it will put you down on the ground so that you get equal pressure through the body, so that that blood can then get to the brain where it needs to be.
I just realized I have a history of passing out when working out. Oops.
Huh. How's your valve doing? That's one possibility. All right, so the real question now is, did we see Michael's valve well enough as we've scanned each time? Have we noticed 3 leaflets? Have we noticed that they're opening correctly? If you're a hypochondriac, as we go through all these pathologies, you can be like, I have that, I have that, I have that.
I think we should give Michael a stress test.
Well, if he's passing out, I'm a little concerned about doing a stress test, to be honest.
I'm like fairly confident it's my lungs because my lung capacity is garbage, but like it could be related to the heart. I have had echoes done because of that stuff.
So we do want to pay attention to your aortic valve for sure. All right, so right heart failure. So with the right heart failure, if a patient comes in, what you're going to notice on the physical exam is things like jugular vein distension. Like when we all talk and we're like arguing and stuff, you see that vein start popping out. Well, if the patient's breathing normally, but those veins are still distended, that's a sign of right heart failure. Okay. It's normal to see it when somebody's exerting, but when they start breathing normally, that usually goes down. They might have hepatomegaly, and again, hepatomegaly is enlarged liver. They might have peripheral edema, so edema and swelling out in the arms and legs in particular. In fact, it's usually a pitting edema that you can kind of press your finger in. It leaves a little divot there for a while, and it slowly comes back out. Ascites. Ascites is a pretty severe stage. It's usually found in people with like cirrhosis, like liver cirrhosis and stuff like that. They get an accumulation of fluid in the peritoneal cavity in various areas, and it can be caused by right heart failure as well. And anasarca is basically a severe edema of the organs, of the internal organs. So the organs themselves are becoming inflamed and edematous. Okay. All right, so on the physical exam, so you're going to notice a lot of things that we talk about, just like in EKG, when you had all those different rhythm abnormalities, we noticed that everybody had shortness of breath. We gave everybody oxygen, right? It's not really a narrowing feature. So we do want to pay attention to things that differentiate this from something else. The first one on this list on the physical exam is fairly specific to aortic valve, and that's a narrow pulse pressure. What does that mean? That means that from systole to diastole, my pressure is close. You're going to have basically low systolic blood pressure, but my systolic and diastolic pressures are going to get closer together. Yeah, go ahead, Mike.
So is all this still related just to AS, or are we talking like more?
Yes.
Okay.
Yes, it's AS.
So, but the previous slide was more general, could be related to lots of things. Is that correct?
Well, these are things that are specific to aortic stenosis, but are not uncommon to be found in other pathologic states as well. Same thing on the next one, but some of these things will be specific, more specific to aortic stenosis than the others, but you do want to pay attention to these things. There's other things that will come out later in other areas that clearly are not related at all to aortic stenosis. Nancy, you had a comment too?
So what would be an example of the narrow pulse pressure?
So narrow pulse pressure, this is like cath lab type stuff. They're taking the pressure in the arteries. So you're looking, well, if you're taking like a blood pressure, so we take a systolic and diastolic blood pressure when we're listening to it with the stethoscope. We report it in systolic over diastolic. When those numbers get closer together, and particularly with a low systolic pressure, we are going to certainly consider that aortic stenosis might be a problem. And
So it'd
thinking
be
of it-
like 90 over 85.
yeah, exactly. So you're thinking of it physiologically, you're trying to press that out. It's not that the heart isn't able to, because maybe the heart is a very strong pump and it's probably got some hypertrophy going on because of it. But it's trying to squeeze, it's trying to get it out, but we have a restriction. We can't get it past the restriction fast enough. And so the arterial system is not filling up like it normally would that rapidly. So I've got it's basically dampening what's going downstream. So just like if we had a stenosis in the leg, downstream, we expect to see a drop in pressure because it just can't get it there. And we expect to see a reduction. We get our tardus parvus because we get a reduction in the systolic upstroke because of it. Kelsey?
Type
Oh,
it, we'll
there
be
we
your
go.
voice. Oh, yay.
I don't know. It keeps, every time I press it, it like stops. But okay. Anyway, at one point, do you say, it's just, I don't know. I guess I'm just confused. You can have a narrow pulse pressure when you have like a hypotensive patient though, right? Do you get what I'm saying?
Yeah. So
I guess I'm just confused.
These are going to be pretty severe, but as it notes that the systolic pressure is going to be a low systolic pressure anyway. So a hypertensive patient is going to have a high pulse pressure on the systolic. Does that make sense? So again, it doesn't totally prove aortic stenosis. It just makes us think, I need to pay attention to that. Okay, hint, as we talk about aortic regurgitation, that one's going to have a wide pulse pressure. And just think of the volume that's going into the aorta and the arteries versus, with stenosis, I'm being restricted. With regurgitation, a lot of the flow goes back, but then I have extra volume coming out.
I'm just trying to think like, oh, if there was a patient in the ER and they had like a severe AS situation and they had a narrow pulse pressure, but they had like a 70 over 50, would that be considered a narrow pulse pressure?
Yeah, 70 over 50 would be pretty low pressure anyway. Yes, that would be considered narrow, but usually your classic is like 120 over 80, something like that. A lot of our hypertensive patients have a high systolic pressure and low diastolic. So it depends on if they're being treated with medications. It depends on if they're untreated. If they're treated and have high blood pressure, they may be back down close to normal range, but still have high blood pressure fundamentally. It's variable. It's just one feature that might suggest that we have something going on. So if I've got my patient that's having syncopal episodes that comes in with a narrow pulse pressure, that's two things that suggest it's aortic stenosis. And regardless, I'm certainly going to be paying attention to the aortic valve anyway. But these clues might suggest that when you start scanning, that you pay particular close attention to that.
Okay, I'm thinking of ER indications right now.
Right. Yeah. Mike, did you have a question too?
Is there a specific range that like a range of like 30 between the systolic and diastolic that we would categorize as narrow pulse pressure, and what would we categorize as low systolic pressure? Is there a ranges or stuff like that we can use?
So you know that your normal pressure is about 120-ish on your systolic.
Yeah,
So if it's
mine's
lower than that,
like 98 over
then I
46
might
though.
consider it.
So
But it really does depend on the patient. I'm not sure there's exact cutoffs for those numbers. It's just noting that they're close together. How close? I mean, normally you're like 80 to 120, so that's like 40 millimeters of mercury difference there. If it's getting less than, I'd say probably 20, like 20 or less ish, I would certainly be wondering about that. If it's, 30, 35, depends on what other things on the
yeah, and then like what about like low systolic blood pressure? Because like I run sometimes at like just 98, 96 in there, and that's considered very low for some people. Is that just
yeah, that might be
patient by
part of
patient?
that might be part of your syncopal problem.
Is it the low that is less than 110
Yeah, if you're less than like 110
or
I'd
70,
say,
less than 75 still?
I would say if your systolic's getting down around 100, you're probably looking at a definitely low pressure. 110, I mean, that can still be normal for some individuals. because we're not always going to fit that exact same mold per se. But just note that those pressures are close together if you happen to see that information. Now we may be taking blood pressure, so we may notice this, or it may just be recorded in the chart. Nancy, did you have a comment as well?
Oh, I just know that they don't let you donate blood if your systolic is less than 100.
Yeah. Yeah, we don't want to cause fainting.
Yeah, I've been turned away because of that before.
Or over 140.
I have a daughter that kept getting turned away because she was less than 110 pounds, 5'3". Wish I had that problem. Anyway, so blood pressure, that's one thing. So another one is tardus parvis on the carotid. So maybe they had done a carotid exam, found the tardus parvis, also probably a low pulse intensity. The anacrotic notch of the carotid pulse might have a notching of the upstroke, so that indicates a severe aortic stenosis. So a lot of these get more prominent or more obvious when it's a severe stenosis rather than a mild stenosis too. That should always be noted. A systolic thrill palpable at the aortic area. So what do you think that is? Remember, this is physical exam. Okay, so you ever get the doctor, so they'll listen with the stethoscope, but sometimes they put their hand on your chest. Okay, so what do we know happens on a stenosis in the leg, for example? If you were to hold that area or to, what do we know happens in the hemodynamics after a stenosis in like a leg?
Turbulence, is that what you're asking?
Yep, and turbulence causes what?
More.
Bruit.
A bruit. The bruit is a vibration. So when we palpate a systolic thrill on the aortic area, you can feel that bruit. It's essentially causing a bruit. It's no different than any other stenosis.
Scott, is that brewery, is it the same like a murmur?
It can be a murmur, yes. It's not always a murmur per se.
Not always. It's
You may
not the same.
feel it. But when you get a stenosis, it's definitely going to vibrate the tissue. That's what a bruit is. And that can be felt in the aorta. If you're getting like a mitral valve, for example, you may not feel that, but you could hear it. Okay? And a murmur is any type of sound coming from the heart that's not normal.
How are you palpating the aortic area?
Well, you can literally put your hand on the chest.
Oh, wow.
You could feel it. Yeah, it's not that you as a tech are going to do this. This may be findings from a PA or a doctor, somebody or a nurse practitioner who's doing a physical exam on their patient. So you might find these notes in the patient's chart. Okay, and then so we got the thrill, we got the pulsus alterans, so it's kind of alternating pulse intensity. That goes along with the left ventricular heart failure, severe. Left ventricular apical lift or heave. So what this is when the heart contracts, it kind of hits the chest wall, but it kind of really pushes. So when something really pushes, you can see, if you look at a child's chest wall, you can see where the heart is beating. Okay, that becomes more prominent in an adult too. Typically we got a bigger fat pad through that area, but you can see that giving that lift or heave on the chest wall just as you're observing the chest without clothing on, or at least on the chest part of that.
We've seen that on Graham.
You see that on? Yeah, you can. Yep.
Do you see that with people with the concave chests?
You might. It's just going to get more prominent. And the reason is now the muscle's squeezing harder, it's working harder, so it's kind of pushing up against the chest more. So you sort of have to have a bit of a baseline for that patient, know what they look like sort of normally to really appreciate it. But if you're getting that major heave and you have those other symptoms going on, we're going to be considering stenosis for sure. Okay, so what are complications of aortic stenosis? So we can have left ventricular pressure overload. and hypertrophy. So we're going to get thickened muscle, and it's going to be getting an increased pressure inside the LV simply because we can't get the volume out, and we're getting a continued volume coming in from the left atrium. We'll have increased end diastolic pressures as well. So our preload and afterload are really going to be increased. Increased left atrial pressure. So again, it just backs up through the whole system. Left ventricular systolic dysfunction may occur. So if it gets severe, the heart eventually is going to start giving up. Might have increased pulmonary artery pressures, which is rare. GI bleeding. So we might, when we get these increased pressures, we can get bleeding through varicosities and stuff that start leaking into the gut. Increased systemic embolization or risk of it, increased risk of infection or endocarditis, increased serious cardiac arrhythmias. So anytime we stretch a chamber bigger than it should be and put undue stress on it, we stand the risk of affecting the electrical conduction. Increased risk of sudden death and pulmonary hypertension. Kelsey.
I mean, I guess I can understand how varices can be developed with like right heart failure, but how can you get varices with?
It would really get that way because it backed up through the right heart as well. It's not going to go directly from the left to those varices there. That actually has to go through the right heart. So that's a pretty severe disease state. It's actually going to be causing basically a cardiac cirrhosis of the liver.
Okay, so you're saying because the left heart gets so backed up, it's backing up then to the right heart, causing varices.
Yes.
And how do you get GI bleeding? Because it goes around.
So when you get when the blood flow out of the portal system can't get through the liver because of that added pressure, it finds a different way. So basically recanalizes the umbilical vein, and then that can go to various places, or it's going to go through, and some of those vessels will actually connect to vessels around the esophagus, and that's what causes the varices. And then those varices, as you're eating, you might be eating raw food, it may scrape it, and then that starts to bleed into the stomach. It's a huge backup of problems, and it is kind of a chronic long-term type of thing. Yeah, if it gets to that point, they've got some major issues going on for sure. I don't recommend waiting that long to go get medical care. All right, so what is the goal of echo? So our goal is always to prove what's going on. So we want to establish the diagnosis, we want to quantify what's going on, and assess the function, both systolic and diastolic. Okay, and in particular, since we're dealing with the aorta, we're going to be focusing on the left ventricle. Okay, so first of all, with B mode, so we take our B mode scan and we want to know, what does the valve look like? So we already talked about, is it thin, pliable leaflets? Do they open freely and completely? Do they close appropriately? Are the leaflets thickened? Is there anything hanging off the leaflets or attached to it? What does the annulus look like? Is it thickened? Is it normal appearing? Are there 3 leaflets? And what measurements do I need to take? Okay, so there's always going to be 2D measurements. So let me ask you first then, from what you know already, what applies to the aortic valve that I would need to take a 2D measurement of?
Aortic root diameter, LVOT, ascending aorta check.
Okay,
I
some of
feel
that
like there's
secondary one is direct.
Yeah,
direct.
the
You want a
LVOT
VTI?
is kind of
Okay, the direct one on the 2D is going to be the LVOT diameter, because that goes directly into our continuity equation. Okay. The other ones are good. Yes, we want to look at dilated post-stenotic dilation in the aorta. We want to see that the sinuses of Valsalva or the aortic root is in normal size, because it can dilate after a stenosis as well. But those are both secondary.
How common is it that a lab does do a 2D aortic valve area in short axis?
As far as tracing it, I would say not common. Most often it's done with continuity equation using Doppler.
Okay.
Yeah, that's by far most common. Nancy?
So you do the LVOT diameter and then you pulse wave the tips in apical short axis.
So you're
I mean long apical long axis.
So not the tips, but you're going to do the 2D LVOT diameter, and then you're going to
Mhm.
pulse wave before the valve inside the LVOT where you took your cross-sectional measurement.
In 5-chamber or 3-chamber?
Either one is acceptable, but either one you want to have that perspective from the apical perspective for sure. And then the other thing that we take is a continuous wave through the valve itself. So, which is technically the valve tips. That's where the highest velocity is going to be. All right, so Doppler assessment. So we do color flow. So you're always going to want to show color flow. Again, as a valve becomes stenotic, you can see the flow confluence starting to come together, and it's going to start to alias more. So always use that to guide your cursor. Simplified Bernoulli equation gets our peak instantaneous gradient. We're looking for maximal velocity. Regardless of how we do it. So on a normal aortic valve, we're going to do those measurements. We're going to take PW for the LVOT. Typically, we trace the LVOT with our VTI, and typically we will take a pulsed wave of the, continuous wave, but just a peak velocity of the aortic valve itself. When it's normal, when it's abnormal and we've got stenosis, we always trace the valve because the tracing gives you more accurate information. In addition to that, you should typically be taking 3 consecutive measurements on normal rhythms. If it's abnormal rhythm with AFib, we need to be taking 5. Okay, again, that's just for our measurement accuracy as far as that goes. You don't want to base it off of one single measurement. Okay, if we do in fact have stenosis by lab accreditation, if a lab is accredited through ICAO organization, you have to do a PDOF measurement with the right parasternal. So on the right side, a little bit higher, you need to take a PDOF sample of that for lab accreditation purposes. So that's required on all aortic stenosis studies. So that's your blind PDOF probe. We're only going to use the highest velocity jet through the vena contracta. So where we find that highest velocity jet, we're going for the highest for that typically. The mean gradient will be the trace. And again, once it becomes stenotic, you want to be tracing it, not just taking a peak velocity. Cath lab uses differences between the LV and the ascending aortic pressures. We use the peak velocities. So we're going to be using slightly different data than the cath lab uses to do comparisons. So when we calculate our valve area, it's done slightly different methodology. Okay, so we do dynamic measurements. We're going to have a very heart rate, load conditions, blood pressure, and inotropic state. We can underestimate or overestimate depending on what's going on, like bad angle, or if we have like an MR jet. Just note that those are kind of pitfalls of echo. We need to make sure that we've got the best angles and best information we can. And continuity is the equation that we typically use for most valve studies. This is how you're going to quantify how stenotic it is. The planimetry of the valve itself in 2D and short axis is a way, but it's a very low accuracy compared to continuity equation in Doppler. Okay, and then this picture just shows the down and dirty. When I go into the echo room, what am I doing? I'm getting that cross-sectional area in my parasternal long axis and getting the pulse wave of the LVOT with a tracing and CW through the valve. Typically, it is 5-chamber just because that's usually what we get to first. 3-chamber is perfectly acceptable. And I would argue that we often see 3-chamber better than we do 5-chamber anyway, as far as the aorta goes. So we've kind of beat this equation to death, but that is your bread and butter for this. Yeah, Nancy?
Why is it, what is the TDI over the TDI? What?
What is the, say that, so the TDI over the TDI?
Why is it TDI OT over TDI AS? I thought it was just the VTI. I mean, TDI and VTI, same thing, but why is it OT over AS?
So one is the outflow tract and the other is aortic stenosis. So one is through the LVOT area. Remember that your continuity equation is the flow going through the LVOT, compared to the flow going out the aortic valve itself. So the AS is the aortic stenosis or the aortic valve itself. And we do trace that again when we get into once our velocity spikes and we do think we have stenosis, we're going to trace it and not just take a peek.
The OT is the pulse wave and the AS is your continuous wave measurement?
Correct, yes. Yeah, so one is of the LVOT specifically, and we have to use pulse wave because it's range specific. Where the other one, we know we're going to get the highest velocity through the aortic valve, so we use CW for that one. And then we do trace it once it becomes stenotic.
Here's an easy answer to the homework question.
So I didn't realize that it was the pulse wave divided by the CW. I just thought it was one or the other. That's a good clarification for me.
Oh yeah, in the equation, yeah. So that's just because we took, so it would have been the cross-sectional area of the LVOT times the TVI of the LVOT equals the TVI of the aorta and times the cross-sectional area of the aorta. What we don't know is, and what information we can't get directly from the information we take is we don't know the aortic valve area, the cross-sectional area of the aortic valve. So with algebra, we just kind of move stuff to the other side of the equation and we simply divide that by the VTI of the aorta. And so that's just a mathematical, just, solving for X. And in this case, X is our cross-sectional area of the aortic valve, or what we call the AVA, or the aortic valve area. Does that make sense? Okay, and that's all it is. So we're taking two individual locations, we're sampling those, we're finding the flow through each of those, and then deriving the valve opening based on solving that algebraically. So every aortic valve study you get, going back to Irina's point of the competency exam, if I ask you for aortic valve study, you definitely got to be taking your LVOT diameter. You need to take your pulse wave and trace it. You need to take your CW and at least get a max velocity, if not a tracing of that. That's what I need to have in my echo to be able to even get a valve area. If I don't get that, I did not do the job that I need to do. In addition to that, you could look for things like dilated vessels and things like that, and hypertrophy left heart and maybe even dilated left ventricle, stuff like that. Those are sort of secondary signs. But I definitely got to get the continuity equation complete. That's a must. You could also trace the valve if you had to, but that's less, certainly less of a quality.
So,
okay, so yeah, go ahead, Stephanie.
The machine calculating the continuity equation, or are we taking our information and doing that ourselves?
So if you plug it into the calculation package, which you should always do, the machine will calculate for you. At the end of your study, usually you should go through and pull up the report pages because that's where you're going to find the calculated values. Okay. So I always recommend taking pictures of your report pages when you're finished. Okay. Newer pack systems, and we have the ability to do it here. I just choose not to because I think it's good for students to go through and manually input it because then you become more familiar with the process. But new systems will actually transport, if you use your calculation package on the system, it will automatically transport it into the report pages for you and put the numbers where the numbers belong. Then the doctors go through and evaluate those numbers based on that. But it's good as a student to go through that process manually so that you know what to change, okay, and what's going on. And it just triggers in your mind. It's like, oh yeah, I didn't notice that number was higher than it should be, that kind of thing, or lower. So use your report page, take a picture of the report page. If you don't use your report page, then you get to do it by hand and you get to hand calculate it. Again, I have one student going back several years now that did his clinical up in Great Falls, Montana, was at his uncle's office, and his uncle made him hand calculate every measurement. Okay. Yes, it would not have been very fun, but did he know how those calculations all worked in the end, you knew them better than anybody else. Okay. So forcing yourself to go through that's not a bad thing. It is tedious, yes, but initially speaking, you'll have a much better and deeper understanding of what goes on. But rule of thumb, use your report package and the calculation package.
Scott, so
Okay.
you said, excuse me, so you
Yeah, go
said we do tracing, is it in a pulse wave? Right?
You're gonna trace the VTI and pulse wave for the LVOT. And if it is stenotic, you're also going to trace the CW through the valve. We only take a peak velocity as we're screening people because it takes time. I mean, you guys all done VTIs. It takes time, and it's always, it can be difficult sometimes to stay accurate on it. But the biggest thing is it takes a lot of time to do. So we just do a screening. If it's not over like 2 meters per second, we're not super concerned about it. We just move on. We don't need to do a full study per se as far as getting a detailed aortic valve area when we can see that the valve works just fine. Okay, when it is stenotic and we start quantifying it for real, we need to trace it. Okay, does that make sense? So
Yes,
you're going to trace both the LVOT and the aortic valve in that case. Okay, so other approaches then to quantifying stenosis. So the continuity equation is one way we already talked about. Planimetry is another way. Aortic valve resistance depends on the ratio of the mean pressure gradient and the mean flow rate. Okay, so these are just in the textbook. They're just other ways. I'm not going to go into super detail on these because you're typically going to do continuity equation, and that's the mainstay. The other ways are just less accurate. LV stroke work loss formula is based on a principle that the LV expends work during systole to keep the aortic valve open and eject blood into the aorta. That's just the concept of that particular methodology. And then just a chart.
Scott, can you go back to those pictures?
These here? Yep.
What is going on in there on the
Good.
one?
So
Oh, the other one on the aortic valve.
this one here.
Yes.
So what do you think is going on in that? So describe this valve to me. So this is presumably valve closed, valve open.
calcified.
Valve is open.
Okay, so we will assume that the one on the left is a normal valve, has normal thickness. It's coapting all the way, it's shutting all the way. So let's just assume that the picture on the right, and I don't have the description in front of me here for this. Hold on a second. I got a mess popped up on my screen and I can't seem to get rid of.
It kind of looks like the left and the non just have irregularity.
Yeah, so anyway, I can't get this message down. I'll look at my other screen. So, so the picture on the left is a normal valve. It's normal thickness. We'll assume that this is the valve. Well, that's the valve shut. And then the other one is just the valve open. I think all I'm trying to show here is that when a valve isn't quite normal, it looks like it's thickened, like those leaflets that you can see on the right picture on B. Looks like some thickened leaflets. It is open. It's triangular shaped. So is it fully open like we normally see? Maybe not quite, but this is if it is stenotic, and you would only tell that by the velocities. This is not a very super stenotic one. This would be like a mild at best if it's elevated velocity. The one on the right is just a closed valve. And I think I'm just trying to show the difference between the open and the closed valve, what you should see. If it's not that nice triangular shape, you're probably getting a stenotic situation.
Thank you.
Yep. So definitions. So if you look on the ASE documents, there are a ton of charts nowadays because they differentiate it between gender and even race at times, because different races and different genders just have different sizes of valves and normal values for those individuals. This is kind of a very, very generic one. inclusive of all people basically. And so we have the mean gradient, the peak gradient, and the valve area. So again, the thing I always want reported is the valve area. So you can see the normal valve is between 3 and 4 square centimeters is our units. Mild is going to be 1.6 to 3, moderate and severe, etc. What I really like you to know as students is I want you to know the normal values, and I want you to know when it becomes severe. Okay, I think those are important numbers to know because in mild, we're usually just following it. Moderate, we're usually just following it, and you usually have charts and tables and stuff like that that kind of help differentiate in your lab. But it's important to know when it's severe because that's when they start doing something about it. That's when they start doing surgeries or procedures to fix it. And we also want to know when it's no longer normal, when it's starting to become abnormal, we start needing to pay more close attention to it. So I like you to know as a student what's normal and when it becomes severe. Okay, fair enough. Otherwise, we can just make you memorize all the numbers. That's no fun. And then the other things that they commonly report on to determine the valve's degree of stenosis is also the mean gradient. So that's given to us by tracing it and the peak gradients. So those, as you can see, change with that. So again, know the normal and know the severe. Yeah, Nancy?
Are they both CW?
Yeah, these will be from your these will be from doing the continuity equations. So yes, you'll do pulse wave still in your LVOT, but CW through the valve.
Is the mean gradient from pulse wave and the peak?
These will be from the CW through the aortic valve itself.
Okay, thank you.
Good. 15, we just got a couple of slides left is all, and I guess appropriate time with that as well.
Hey Scott.
So, yeah, go ahead, Mike.
So I was looking through the book on the like cross-sectional area of the aortic valve, and I was seeing like 2.1 centimeters is normal. Is that different than we were just talking about, like 3 to 4 centimeters? Sorry, I got a little bit lost there.
You're talking.
Yeah, I saw that too.
The normal. So what page are you on?
199. Oh, it's talking cross-sectional area. We're talking valve area here, so that's probably why there is a difference. Sorry, I just remember it from like the hemodynamics chapter.
Right.
Like Darren says, how tall's a woman? So
Yeah, I mean, it may vary slightly on the. You're on page 199, you said?
Yes.
The new book or the old book? Oh, never mind. That's it.
8th edition.
Can you clarify what we're looking at for this valve area measure, these numbers? So is that?
Say that again, Kathleen.
So where valve area, where is that coming from? The normal 3 to 4 precisely?
Those are just from research. So that's the
valve area of the valve opening?
Yes, so
it's
continuity
equation?
Yeah, it's based on the continuity equation, and it's based on, I'm going to say it's based on continuity equation, but it could be from surgical experience and stuff like that, and just actual samples of valves, just knowing the total cross-sectional area of normal valves. I'm not sure exactly where that data comes from. I would presume continuity equation, but our gold standard is surgery. So we're comparing to when a surgeon actually looks at the valve and actually takes measurements of the real valve. I'm not seeing it on page 199 here, so that's in the right part.
Figure 8.12.
Here it is. If you look at my video, I'm taking it of the.
Oh, that one. So that was just I don't know if that's necessarily showing a normal valve. That's just showing a representation of how the cross-sectional area with the TVI just stays consistent from one valve to the next. That's not necessarily showing a normal.
Yeah, and that's a measurement of CSA, not valve area. So I think that's where I got confused looking at the
Yeah,
normals, that kind of thing.
yeah. So I would go off the charts in the chapter for that, and they should be consistent with the ASC as well standards. And they
I
do
have a
try to keep the numbers to be like, you notice when it hits severe, it's at 1. They try to keep these numbers fairly easy to remember type of numbers and not like decimals and stuff like that, because you know they could set the threshold differently. They chose to set it there so it's easy to remember. Nancy?
Is cross-sectional area the same thing as valve area?
Yes.
So Michael, when you're thinking that valve area and cross-sectional are different, they're not different, they're the same thing?
That depends. If you're talking about LVOT, we do a cross-sectional area there, but the cross-sectional area of the valve is the AVA, is the valve area. The LVOT cross-sectional area is a different location.
So what numbers does that give you differently then? Are you doing just
These cross-sectional areas
proximal and distal?
well, these cross-sectional areas are giving you specifically how, when the valve is fully open, what is the hole size?
So the valve cross-sectional area is obtained by doing your continuity equation. The other cross-sectional is your 2D measurement, which is of that, right?
Correct. Yeah. So when we do the LVOT, we're measuring it by diameter and plugging it into the pi r squared or the 0.75785, whatever, times the VTI. So that gets us the cross-sectional area of the LVOT. We can measure that and extrapolate that mathematically. We can't, because of the shape of the aortic valve when it's stenotic is a very odd shape. It's not an easy mathematical assumption. So we can't just take a diameter and derive it. We have to derive it based on the continuity, comparing one area of flow compared to the other area of flow, and then mathematically deriving from algebra what the cross-sectional area of the aorta is, assuming that what went through the LVOT also went through the aorta.
So in like aortic stenosis, that's when we are using the equation that we have. And the other times we can just measure the cross-sectional area, like boop, boop, and use the normal. Okay.
So we can more directly measure LVOT cross-sectional area. We still make assumptions, but not the same. Because the aortic valve, when it's stenotic, it can be very odd shaped and it's very hard to just make assumptions about. And it's more important that we get accurate measurements there anyway, because we do base sometimes the surgery decision based off of what we find. Nancy, another comment?
So we use the continuity equation. If we're doing it at the LVOT level, that is the blood flow amount exiting.
Yes, stroke volume.
If we do it at the valve level, that's the actual opening size of the AV.
Yes.
Thank you for making that. Thanks. I think I got it.
Yeah, it gets confusing because we're technically measuring 2 different locations, but we use one formula. So we assume that it's all about that valve. Half of that formula, remember, is coming from the LVOT. Half of that formula is the comparison to the aorta. And we're just solving for X, which is, in this case, our aortic valve area, which is the cross-sectional area when the valve is open. That's too much for the end of the lecture. Yeah, just noodle that for a while. I think it just takes some time, go through that formula, but when we're measuring the aortic valve area, what we're interested in is when the valve is fully open, how big is the hole? Okay, just like when we start looking at regurgitation, the thing we're looking for there is when the valve is closed, how big is the residual hole that's allowing the leak? It's the hole size that we're interested in. Okay, so dobutamine and stress echo can be used, even though the EKG book said that aortic stenosis was a contraindication to doing a stress echo. We can use like the dobutamine stress echoes to determine the severity of stenosis and prove or disprove how severe it truly is. Because part of that valve stenosis, yes, we get a restriction in opening, we get our waveforms and stuff like that. But what if the left ventricle is not working so well? What if the ejection fraction is very weak and low? Then it may not have enough pressure to even push against the valve to open it fully. So the idea of these stress tests is that we actually cause that volume and pressure to increase, and thereby seeing if the valve actually will open more than it really is. If it's truly that stenotic, it will not change the size of that aortic valve area. If we do the dobutamine and then the valve starts opening more, then our valve area will actually become bigger, which is good. So that will help, again, plan whether somebody's going to send them for surgery or if they're not, and you're just going to keep following them up. So the weakness of the heart may have an influence on how well that valve opens. And the dobutamine stress echo is one way to help prove that it's actually opening more than it looks like it is, or proving if it is in fact that stenotic. So it can help to determine between those for that. This is a patient over a 2-year period. So you can see you're looking at the peak gradients and the peak velocities. You can see that each of those increases over time in that 2-year period between figure A, B, and C. You can see that those velocities go up, but also the pressure gradients go up. These patients will often be followed over time. They'll be scanned usually about once every year, once every couple of years. Because it is a slow process. It's not a fast process to become stenotic. It's very gradual. And we just want to see when they get to those stages. So once they become severe and beyond, that's when we start to actually do something about it. When it's mild and moderate, they might be medicating the patient. They might be controlling how much exertion they put upon themselves, things like that to help control it. But at some point when it becomes very severe, they have to actually surgically do something about it, or doing like a TAVR type of a device where they go in, balloon angioplasty the valve out, the native valve, and then implant a stent valve in its place called a TAVR. And they may actually do a procedure there. So typically you're going to follow up these patients over a long time. Clinical decision making, and as a good rule of thumb too, when you see your patients come into the lab even, sometimes we get pretty excited about what we see and we're all like, oh, I just saw this. Keep in the back of your mind, the number one question is that patient symptomatic? Okay, if they are not experiencing symptoms currently, it's probably not as bad as you feel it might be. And so, but if they are experiencing symptoms, that's usually a clinical decision maker. So if they start experiencing symptoms and it's bothersome to them, that's when they start thinking about doing something more than just medicating and stuff like that. So symptoms are a big decision maker point. Asymptomatic with significant aortic stenosis are medically managed with medications and diet and exercise and that kind of stuff. We want to track for progression of aortic stenosis and the LV function. So anytime we look at the stenosis of the valve, we're also paying attention to the function of the heart, okay? Because again, if the left ventricular ejection fraction drops down and we get poor systolic function, that's going to affect what goes through the valve and how well that valve opens. Valve recommendations, 11.6 isn't the accurate table anymore, but it's in the chapter. Was that chapter 10? I believe it was.
Chapter 10, it's table 10.6 on page 266.
Perfect. So these should relate. The 11 is just because it used to be in chapter 11 and they moved it. But again, valve recommendation table there for replacement. Symptomatic figure 1127 should be 1027 also. And always consider in relation again to the left ventricular function is kind of the take-home message for that.
So
And
do we need to,
go
sorry
ahead.
for interruption, do we need to know this table? Do we need to memorize it?
Let me look at it real quick. It's 1027, right?
266 is the page.
Thank you. No, just vegetation. Oh, figure 1027. Yeah, 266 is into regurgitation. Yeah, no, don't worry about memorizing those tables. That table with the stenosis with the mean gradient pressure, peak gradient, and valve area, that's on page 257. That's 10.4. 10.4. Yeah, don't worry about that. Clinical decision making then is this is just an algorithm of how they look at it. So again, as a screening tool, we look at the velocity, the max velocity, just with we'll take our CW through the valve, we'll take a peak velocity of it, and that's sort of our first stage of determining where it's at. So this is adult with aortic stenosis symptoms being considered for aortic valve replacement. Okay, so these are well into the stenotic range. Anytime you get over a velocity of 1.5 to 2, those are elevated velocities. If it gets over 2, that's a stenotic velocity, and we start tracing it. But at that point, we're certainly not considering valve replacement. So these tables are going beyond this. And it's just showing the algorithm and the thought process of the clinical decision making. So the AVR recommended is meaning that the aortic valve replacement is recommended. So those sets on the left side of that picture are recommending valve replacement of some kind. And then the ones on the right, it's not needed for those. So from the Doppler and from the AI severity and stuff like that, those are just things that help them make the decision. Should we do a surgery and replace the valve or should we not at this point and just medically manage them? You don't have to memorize this table. I'm just kind of giving you a flow chart of how they make those decisions. Yeah, Nancy?
Sorry to keep asking questions and running long. What is AVA? Doppler AVA?
So AVA is aortic valve area. So that's Dopplering for the aortic valve area. So that's doing our continuity equation. And so that these reported numbers here, this is the cross-sectional area of the aortic valve itself when it's open, fully open. So as you can see, the less than or 1 equal to 1.0, that is severe. If it's greater than 1.7, that's in like the moderate to mild range. Okay, but the 1.0, less than 1.0 is severe. Again, that kicks it over to the recommendation to actually replace it. Okay. That is valve stenosis. So next lecture tomorrow will be on regurgitation. This is the fun stuff. This is when echo starts getting fun. We get these weird things.
I agree with that. I think that's better.
It's more, it keeps you engaged mentally. It's awesome. All right, so that's all I've got for today. Any other questions?
Yes, Casey has one about the class, and I have an idea to throw out. What if the
This class?
quizzes, yeah, for this class, what if the quizzes were closed earlier, like before class or right at class, and we went over them live?
I can do that if everybody's willing to take them before.
I'm fine with that.
Me too. I'm fine with that.
Yeah, I'm fine with that too.
I'm good with that.
The bigger question is anybody not fine with it?
Yeah.
I hate mornings, but I'll do it.
And if you don't want to admit it, then email me.
Oh, that was good.
That's fair. That's a good question. That's a good out because
Yeah,
I feel like we're peer
not
pressure.
everybody wants to be put out there.